Welcome to the Intranasal Naloxone Education and Training module for Ohio EMS. On October 16, 2013, the Emergency Medical, Fire, and Transportation Services Board amended the Ohio EMS Scope of Practice for intranasal naloxone administration. The board expanded the scope of practice to allow emergency medical responders and emergency medical technicians upon completion of training and with the approval of the medical director to administer intranasal naloxone to a person suspected of suffering from an opioid overdose. This training is conducted by Miller Training Solutions, and continuing education credits are brought to you by Warren Township Volunteer Fire Department Education Program, an Ohio-approved CE program. Core content is developed by Ohio EMS. The use and abuse of opioids has existed in our society for centuries. Naloxone is an opioid antagonist and its primary use for the emergent treatment of opioid overdoses. Naloxone was developed in the 1960s during a period in our nation where experimentation with and abuse of opioids became more widespread and less secretive. The demand for naloxone has grown significantly due to the greater variety of types of opioids legally prescribed for patient use and those that are available illegally. This is a list of the legal opioids that are frequently prescribed to patients for pain relief. They are approved for patient care by the FDA. Opioids for pain relief are often combined with other pain-relieving medications by manufacturers. Some of them are listed here. When providing care for a patient who has taken one of these combination medications, it is important for EMS providers to consider the potential toxicity of the other components of the medication. For example, acetaminophen in large doses can cause significant damage to the liver, and an antidote is available. The most common illegal opioids in the world are opium and heroin. Opium, which is derived from the opium poppy, is refined to make both legal and illegal opioids. Legal opioids are also often combined with other drugs such as cocaine, LSD, or PCP. Recently, heroin abuse has had a major reappearance within our society and is causing an increased demand for naloxone. There are three primary routes of opioid administration for laypersons: oral, transcutaneous, in the form of an adhesive medication patch, and intravenous in patients who are discharged from healthcare facilities with IV access left in place. Although some opioids are approved for subcutaneous administration, this route is almost exclusively used by drug abusers with poor veins. The primary signs and symptoms of an opioid overdose are pinpoint pupils, respiratory depression, and decreased mental status or unresponsiveness. Chronic opioid use can cause constipation, but even short-term use will decrease intestinal motility, the movement of food through the gut. The risk factors associated with opioid overdose include hypoxia or hypocarbia from respiratory depression, aspiration, and cardiopulmonary arrest. Alcohol or benzodiazepines, when combined with opioids, increase the risk of all of these. Naloxone works by displacing the opioid in the nervous system and bonding to the opioid receptors.
The blockade of the opioid receptors by naloxone suddenly stops the effects of the opioid on the nervous system. This may cause the sudden onset of signs and symptoms of opiate withdrawal. These symptoms include agitation, tachycardia, pulmonary edema, nausea, vomiting, and seizures.
For EMS providers, the traditional routes of administration of naloxone are via an endotracheal tube, intramuscular, intranasal, and intravenous. The intranasal route for naloxone has become more popular recently. This route has several benefits when compared to IV, IM, and ET routes. Research studies have demonstrated that intranasal naloxone is equivalent to intravenous naloxone in its effect. This is important for patients with fragile veins and for chronic IV drug abusers with poor veins. Starting an IV may be difficult or impossible in these patients, and the intranasal route for drug administration may be their best option to receive medication emergently. Although medications can be delivered via the intranasal route with a simple syringe, but mucosal atomizer devices, or MADs, provided a focused, directed delivery and dispersal of the medication into the nasal cavity. The use of MADs reduces the risk of needle stick injuries and potential infectious disease exposures. On October 16, 2013, the Emergency Medical, Fire, and Transportation Service Board approved expansion of the Ohio EMS Scope of Practice to allow emergency medical responders and emergency medical technicians, upon completion of training and with the approval of the medical director, to administer intranasal naloxone to persons suspected suffering from an opioid overdose. As with all patient care delivered by EMS providers, approval from the medical director is required for the EMS provider to be authorized to administer intranasal naloxone. In addition, a protocol must be provided by the medical director. Training that is approved by the medical director is also required. The Emergency Medical, Fire, and Transportation Service Board determines the Ohio EMS Scope of Practice, and no one, including the medical director, is permitted to exceed this scope. However, the medical director has the authority to limit or prohibit parts of the Ohio EMS Scope of Practice, including the administration of intranasal naloxone. Although EMS providers that are certified as advanced EMTs and paramedics may use a number of routes to give naloxone, emergency medical responders and emergency medical technicians are strictly limited to the intranasal route. Naloxone is provided as a liquid. It can be drawn into a syringe from a vial, or it can come in a pre-filled syringe. The dose of naloxone to be given to a patient is determined by the medical director and should be written in the protocol provided to the EMS provider. Also note, within this scope of practice, it is not permissible for EMRs or EMTs to draw medication via needle. EMRs and EMTs are only permitted to use pre-filled syringes. During the delivery of naloxone by the intranasal route, the tip of the syringe should be placed near or just inside the patient's nostril. If the syringe is placed too far inside the nostril, the nasal passages may be traumatized by the syringe, cause nosebleeds, or other damage. All needles should be removed from the syringe prior to placement of the syringe into the patient's nostril. Needles can puncture the patient's nasal tissues or sinuses and can cause other damage to the patient's nasal cavity. A mucosal atomization device is a soft and flexible attachment that is fitted on or can be attached around the tip of a syringe. This device maximizes the delivery of the naloxone to the patient.
The LMA MAD nasal is the safe and painless way to deliver medications directly into your patient's bloodstream without an intravenous line. To use the MAD nasal, fill the syringe with the proper volume of medication and connect the atomizer. Place the MAD nasal gently but firmly against the nasal opening and briskly compress the syringe plunger. The medication exits the tip of the MAD nasal as a fine atomized mist, resulting in broad coverage of the nasal mucosa with a thin layer of drug. The medication rapidly absorbs across the mucous membrane into the bloodstream, as well as directly into the cerebral spinal fluid of the brain, avoiding first-pass metabolism. This achieves medication levels comparable to injections. Once in the bloodstream, the medication circulates throughout the body. In the central nervous system, it enters the brain and binds to neuroreceptors, exerting the desired clinical effect and leading to resolution and improvement in the patient's symptoms. MAD nasal allows for exact dosing, is titratable to effect, and can atomize in any position.
This picture shows a mucosal atomization device attached around the end of a syringe. Some syringes, like this one, are designed with a softer plastic tip to draw medication from a vial. The manufacturer may package the syringe and the MAD as one unit as shown in this photograph. The soft plastic tip extends slightly beyond the edge of the MAD. This flexible tip of the syringe is too short to cause significant trauma to the inside of the nasal passages. A MAD can also be applied to the end of a needleless syringe. Once the medication is drawn up into the syringe or a pre-filled syringe of the medication is available, the EMS provider should don gloves and the appropriate personal protective equipment before giving the medication to the patient. The patient's head may require manual stabilization by the EMS provider or another member of the EMS team. The narrow end of the mucosal atomization device is placed gently into the patient's nostril, and the naloxone is injected into the patient's nasal cavity. The administration of naloxone may result in the rapid onset of the signs and symptoms of opioid withdrawal. The most frequent signs and symptoms of withdrawal include agitation and combative behavior, tachycardia, pulmonary edema, nausea, and vomiting or seizures. During the assessment of all patients, including those who are suffering from a suspected opioid overdose, airway, breathing, and circulation remain the top priorities. The airway must be secured and maintained with oxygen provided as necessary. Inadequate respiration should be supported with oxygen delivered via bag valve mask before naloxone is administered. If the patient is pulseless, high-quality CPR should be initiated prior to the administration of naloxone. All patients should be assessed for other causes of altered mental status or respiratory depression that include, but are not limited to, hypoxia, hypoglycemia, head injury, shock, and stroke. The adverse effects following naloxone administration, particularly in chronic opioid users and abusers, may place the patient, EMS providers, and bystanders at risk of physical injury. Prior to the administration of naloxone, EMS providers should consider moving sharp or heavy objects out of the patient's reach, or the application of physical restraints in anticipation of combative behavior. Ensure that bystanders are kept at a safe distance. Due to the risk of uncontrollable agitated behavior, pulmonary edema, and seizures, many healthcare professionals will elect to reserve the administration of naloxone to those patients with respiratory depression, impending cardiopulmonary arrest, or shock. When the administration of intranasal naloxone has been approved, the EMS medical director should also provide protocols to emergency medical responders and emergency medical technicians to address the management of the signs and symptoms of opioid withdrawal. Once naloxone has been administered, it is vital to continue to monitor the patient. The half-life of naloxone is brief and can be as short as 30 minutes. As the effect of the naloxone fades, the signs and symptoms of an opioid overdose can return. Recurrent altered mental status, respiratory depression, or circulatory compromise can follow quickly. Therefore, constant patient monitoring and frequent reassessment is essential. Now let's discuss protocol review for naloxone for Washington County EMS protocols in Washington County, Ohio. Discussing therapeutic effects for naloxone. Specific antidote for narcotic agents. This reverses the actions of all narcotic drugs, including the listed below. Narcan is thus effective in counteracting the effects of overdose from any of these agents. Narcan will reverse stupor, coma, respiratory depression, and etc. when these are due to narcotic overdose. Indications. Indications for naloxone include to treat known narcotic overdose or coma suspected due to a narcotic overdose. There are no known contraindications for naloxone. Reviewing side effects of naloxone. Rapid administration may precipitate projectile vomiting and ventricular dysrhythmias. Administration to people who are physically dependent on narcotics may cause an acute withdrawal syndrome. For this reason, Narcan should be given very slowly, using improvement in respiratory status as an endpoint. In general, the duration of action of Narcan is shorter than that of the narcotics it is used to counteract. Thus, the patient who has been successfully aroused with Narcan may fall back into stupor or coma as the Narcan wears off. These patients must therefore be watched closely, and the dose of Narcan should be repeated as necessary. Has been reported to cause pulmonary edema and sudden death in very rare cases. Administration of Narcan has been known to cause seizures when given to neonates who have had long-term intrauterine exposure to opiates. Naloxone is supplied in one of two ways. It is supplied in pre-filled syringes containing 2 milligrams and 2 milliliters. Other combinations of concentrations are supplied in vials. When discussing administration guidelines, EMRs and EMTs must reference the MAD procedure guidelines. For advances in paramedics, you may use intravenous injection. It is as follows: slow intravenous injection as soon as there is improvement in the patient's respiratory or mental status. Stop giving the drug. It is preferable that the patient not wake up fully in the field, as these patients may be violent when brought abruptly out of coma. If there is no response to 2 doses, suspect overdose with another non-narcotic drug. Again, reminding you that the EMR and EMT must use the MAD procedures for intranasal naloxone administration. Adult dosages are as follows. Initial dose is 2 milligrams slow IV push while monitoring the rate and depth of the patient's respirations and patient's mental status. For EMRs and EMTs, your initial dose is still 2 milligrams, only you will administer it via intranasal, 1 milligram, 1 ml per nostril. If there is no response to the full dose of Narcan, it may be repeated in 5 minutes in the same fashion. Pediatric dosage as follows: 0.1 milligram per kilogram every 5 minutes until respiration is improved, a maximum single dose of 2 milligrams. Pediatric dosages are determined by weight in kilograms. To determine the child's weight in kilograms, take weight in pounds and divide it by 2.2. You will then multiply that figure by 0.1 to achieve your dose. For the MAD procedure guideline, you will load the syringe with the appropriate ml volume of medication, recommended 2 milligrams for Narcan. Again, reminding you that EMRs and EMTs may only use pre-filled syringes and may not use vials where medication is required to be drawn from the vial. Attach the mucosal atomizer device. Place the MAD tip within nostril approximately 1.5 centimeters. Briskly compress syringe to administer half the volume as atomized spray. Remove and repeat in the other nostril so all medication is administered, half in each nostril.
And the way that you put this together is super simple. I'm going to take the applicator and I'm going to take these 2 yellow pieces off that you see here. So the first one and then 2. And you'll see that there's a tapered end here and an open end with a needle, and that will allow this applicator to access the medication. The second thing I'm going to do is I'm going to take this vial of medication and I'm going to pop off this cap. It'll be either red or purple, and I just grab it underneath. I put my fingernail underneath, pop it straight off, and then on the inside you can see a rubber grommet. What I'm going to do is I'm going to put the 2 open ends together like this, really gently, and twist until I start to feel a resistance. Then I'm going to take the atomizer, and this turns the liquid into a spray and allows the liquid to go up through the nose and enter through the mucosal membranes and then enter and pop the opiates off of the receptors in the brain. So I'm going to take this atomizer and twist it on the top like this. Now this is 1 full dose and it's ready to go. So what I'm going to do is I'm going to go ahead and administer it in a spray, half up one nostril and then half up the other.
Before you take the test for this education and training module, we would like to provide you the chance to think about the management of 2 patients who are suspected opioid overdoses. You respond to a known drug abuser who is found unconscious with a hypodermic needle inserted into her arm. Her pupils are pinpoint and she does not respond to painful stimuli. Upon assessment of vital signs, her blood pressure is 110/70, pulse is 60, respiratory rate is 2, and a pulse oximeter reading is 84%. What is the first action you should take? Pause the presentation to discuss the case. With a respiratory rate of 2, this patient is apneic. The appropriate initial action is to open and maintain the airway and administer oxygen via bag valve mask. Always remember that airway, breathing, and circulation are the top priority with every patient. In this case, treatment to support the patient's airway, breathing, and circulation should be initiated prior to the administration of naloxone. This is another patient case for you to manage. You respond to the home of a diabetic hospice patient with cancer. He has the decreased mental status and pinpoint pupils. His wife checked his blood glucose prior to calling 911, and it is 170. The patient was at his baseline mental status until she applied a fentanyl patch that was recently prescribed for pain control. He has a blood pressure of 130/80, pulse of 70, respiratory rate of 18, and a pulse oximetry reading of 95%. What action should you take? Pause the presentation to discuss the case. You should follow the protocol that is provided by your medical director. This patient has stable vital signs. Your medical director may direct you to administer intranasal naloxone, remove the fentanyl patch, or transport the patient without any additional medical intervention other than supportive care and patient reassessment. The medical director retains the authority to allow, limit, or prohibit the administration of intranasal naloxone by EMS providers. Regardless of the training provided by a medical director, an EMS provider can never exceed the Ohio EMS Scope of Practice for the provider's level of EMS certification.
I woke up in the hospital, my shirt was cut off and I had bruises on my chest. It was from my mom pounding on my chest saying, "Please don't take my baby boy, please don't take my baby boy."
Luckily for Miles Dawson, his mother's prayers were answered. After overdosing on heroin, he was rushed to the hospital and given a medication called naloxone.
They gave me the naloxone, which reverses the effects of heroin altogether.
Naloxone, or Narcan, reverses opioid overdoses. It's hardly available in Ohio outside of hospitals. But if Governor John Kasich signs House Bill 170 into law, friends and family members of opiate users would have access to the antidote.
It provides an opportunity to save lives, get people the treatment that they need.
State Representative Michael Stinziano is a co-sponsor of the bill, which passed in both chambers unanimously. Dr. Eric Adkins of OSU Wexner Medical Center showed me how naloxone is typically used.
So we would just kind of come to you, support your head here, and then it would come up here into the nose, and then we would inject the medication.
But for some victims, by the time they reach medical professionals, it's too late. Dr. Adkins says the bill will help save people who may run out of time before an ambulance can arrive, as a patient must have a heartbeat for naloxone to work.
A lot of times those patients may have been down for a number of minutes, hours in those cases, and it's not very common that they can be saved.
Almost 4 years after he was saved, Dawson has remained sober. He has a job in sales, just got approved for a home mortgage, and speaks to students about the dangers of addiction. After being saved by naloxone, he says he hopes other addicts will have the same second chance at life.
Naloxone is it's going to be a big saver, like an EpiPen if you get a bee sting. I mean, the possibilities are endless for people.
Reporting for WOUB News, I'm Kaylee Bourgeois.
Thank you for completing the intranasal naloxone education and training module for Ohio EMS and for your dedicated service to the residents and visitors of Ohio. If you have any questions, you can call 1-800-233-0785 or email at askems@dps.state.oh.us.